At the exact moment of fertilization, a single cell initiates a precise cascade of division. Within days, the blastocyst is rapidly expanding, driven by a biological mandate to establish a viable pregnancy. By day 4, the outer layer of this blastocyst has differentiated into specialized cells called trophoblasts. These cells are responsible for establishing a nutrient supply line for the developing embryo and eventually forming the bulk of the placenta. When fertilization is abnormal, this nutrient-driven expansion becomes pathological, replacing embryological development with an aggressive, space-occupying tissue mass. This condition is gestational trophoblastic disease, specifically focusing on the hydatidate form mole, or molar pregnancy. We can see the scale of this disease by comparing a healthy uterus on the left to a molar pregnancy on the right. Instead of a fetus, the uterine cavity is filled with millions of fluid-filled vesicles. These abnormal processes are classified as either complete moles or partial moles. In early gestation, both types present similarly, making it difficult for pathologists to distinguish between a benign anomaly and a life-threatening precursor. The exact chromosomal error at the moment of fertilization dictates the physical cellular growth, the clinical presentation, and whether the mass will eventually transform into choriocarcinoma. This divergence begins at the point of conception, rooted in an imbalance of parental genomic contributions. A normal conception requires one maternal and one paternal set of 23 chromosomes to create a 46-chromosome fetus. A complete mole occurs when an empty egg containing no maternal DNA is fertilized. In one scenario, 2 separate spermatozoa fertilize this empty egg. Alternatively, a single sperm can penetrate the egg and duplicate its own genetic material, as shown here. The result is a diploid karyotype, either 46XX or 46XY, that is entirely composed of paternal genes. This purely paternal genome prohibits embryogenesis, meaning fetal parts will never form within the mass. A partial mole follows a different genetic path. In this case, a perfectly normal egg is fertilized by 2 normal spermatozoa. This results in a triploid state, typically a 69XYY karyotype. Because one set of maternal genes is present alongside the paternal sets, early embryo formation remains possible. While fetal parts may be visible, the excessive paternal DNA renders the fetus non-viable. Biologically, these extrapaternal chromosomes act as a driver for unregulated trophoblast proliferation. The presence or absence of maternal DNA at the moment of fertilization is the single switch deciding between a fetus or a parasitic mass. These microscopic genetic errors eventually manifest as macroscopic physical deformities. This gross pathology shows the result: cystically dilated chorionic villi. These structures appear to the naked eye as translucent, blood-tinged, grape-like clusters. Under a microscope, we can see the specific cellular architecture of a complete mole. In these cases, every villus is severely edematous or swollen with fluid. The margins show diffuse proliferation of trophoblast cells, often presenting with cellular atypia. This contrasts with the histology of a partial mole. Here, the trophoblast proliferation is only focal and slight, and cellular atypia is absent. Only some villi show signs of edema, while others remain structurally normal. These grape-like clusters are a massive physical expansion of cellular villus edema, a direct consequence of uninhibited paternal genetic influence. These internal cellular changes create a specific clinical profile for the physician. The incidence of molar pregnancy is roughly 1 to 1.5 per 2,000 pregnancies, though rates are higher in Asian countries. Patients are at the highest risk when they are under 20 or over 40 years of age. Diagnosis relies heavily on early ultrasound monitoring. The ultrasound reveals a characteristic snowstorm appearance, and in the case of a complete mole, a total absence of fetal parts. This visual data is confirmed by lab results showing massive elevations in serum HCG levels. Because trophoblastic tissue naturally produces HCG, the diffuse proliferation in a complete mole yields significantly higher levels than the focal growth seen in partial moles. The snowstorm ultrasound and elevated HCG are direct, quantifiable readouts of aggressive trophoblastic hyperplasia. After a molar pregnancy is identified and removed, the clinical priority shifts to monitoring the patient's long-term risk. The initial chromosomal error at fertilization determines the oncogenic risk profile for the patient. A partial mole has a more favorable prognosis. These rarely progress into choriocarcinoma. The complete mole pathway carries more significant dangers. 80 to 90% resolve with no recurrence. 10% progress into an invasive mole, invading the uterine wall. Critically, 2 to 3% transform into gestational choriocarcinoma. Choriocarcinoma is a rare but highly aggressive cancer originating from the gestational chorionic chromosome count at fertilization determines the cellular architecture, the lab results, and the patient's ultimate probability of developing a deadly carcinoma.